everybody. For today's lecture, we are going to be focusing on the concept of cardiac output and how does your cardiac output is regulated. So we learned in the previous lecture that we have something called the end diastolic volume, which is basically the amount of blood that it is within the ventricle right before it contracts, and it's about 120 milliliters. And we also learned that when your heart contracts and it's done with its contraction, there's about 50 milliliters of blood that is left inside the heart, and this is referred to as end systolic volume. And the difference, which is the amount of blood that basically gets pumped outside of the heart, is referred to as the stroke volume, which is about 70 milliliters. So if I want to figure out what is the cardiac output, I would consider the number of heartbeats that I have and multiply that by the amount of blood I move every time your heart beats, which again is referred to as the stroke volume. So in average, your heart beats about 75 beats per minute, and your stroke volume is about 70 milliliters, as we decided in a few minutes ago. And diastolic minus end systolic, which gives us about 70 ml. And if you multiply these two numbers, you get a cardiac output of about 5.25 liters per minute. This implies that your blood, basically the amount of blood you have in your body, circulates about one time every minute, because you have a little bit over 5 liters of blood in an average human being. Now, we have something called the maximal cardiac output. So, if you are resting and you're normal, you're not really doing any type of physical activity or stressed out, your cardiac output, as I mentioned, is about 5.25 liters per minute. However, if you start to exercise or put some sort of stress or activity, if you're considered to be a non-athletic person, you can push about 4 to 5 times of your normal resting cardiac output, which basically implies I take 5.25 and multiply that by 4 and by 5, which gives you about roughly 25 liters, between 20 to 25 liters of blood being circulated through the body. If you are an athletic person, that number increased to about 35 liters per minute, because again, you will be moving more blood because your stroke volume is typically going to be higher if you're a non-athletic individual. Now, the difference between your normal cardiac output, which is about 5 liters, and the maximal cardiac output, which in a non-athletic person is about 25 liters, the difference between those is referred to as the cardiac reserve. So in a normal healthy individual, it's about 15 to 20 liters, and if in an athletic person, it's about 25 to about 30 liters, and that are considered to be the reservoir or cardiac reserve for the body. Now, looking at the equation that we have here, if I ask you, how can I change the cardiac output that I have? Since cardiac output is created as a result of heart rate and SV, or stroke volume, if I change any of these two components, basically can change the cardiac output. For instance, by changing the heart rate without changing the stroke volume, cardiac output can increase. I can increase both stroke volume and heart rate, which causes an increase in cardiac output. And also, if you just want to maintain your cardiac output, and let's say your stroke volume drops because you have either a bleeding or dehydrated, then to maintain it, if this goes down, you're going to increase your heart rate to make sure your cardiac output remains the same. So we're going to talk about that in a little more detail as we go through the PowerPoint. So looking at the stroke volume, this is something that I just discussed with you regarding how we calculate the stroke volume. The stroke volume is the difference between end diastolic volume, which is about 120, and end systolic volume, which is about 50 milliliters. And the difference between them gives you about, again, 70 milliliters of normal stroke volume. Now, you can have an end diastolic volume, which is going to be a larger volume, which means you increase the 120 by either increasing the time your ventricle spends in relaxation. And what this means is basically you are going to allow more time for the ventricles to be filled. So more time for ventricles, more time for ventricles to be filled. So increase in time for ventricle filling. And again, that will increase your end diastolic volume. And you could increase your venous pressure. As your venous pressure, basically the blood that's coming back, venous implies basically veins and returning blood. If you increase your pressure, you are pushing more blood back to the atrium. So this implies basically increase atrial return. And the more you return, the more it's going to go down to the ventricles and consequently basically increase your end diastolic volume. Now, end systolic volume also can be increased. So usually you leave about 50 milliliters of blood inside of here, but instead of keeping 50, what I'm going to try to do is to squeeze the heart harder to not keep 50 ml, but instead, let's say, keep 40 ml of the blood. So if I increase this from 120 to 130, and then I squeeze the heart harder to push more blood out, the difference here would be how many? 60 and 30. It would be 90 milliliters of a stroke volume versus the normal 70 milliliters of a stroke volume. So through both of these, you were able to increase your stroke volume. Again, something to keep in mind, there are factors that could be changed in both end diastolic volume and systolic volume that could affect your stroke volume. Now, going into a little more detail and components that really affect the stroke volume and how a stroke volume is controlled is the concept of preload and contractility of the heart. So starting with preload. Preload is basically uses a concept of Frank Starling law of heart. As you increase the stretching of the heart, as the more stretching your heart has, there is an increase in the force that is created. So as I'm stretching the heart to fill it up with more blood coming back to it, the heart is stretching, so when it contracts and push more blood out. So this is a concept of preload, right? Because you are loading the heart with more blood, which stretches the heart and consequently pushes the blood more out of the heart. Do remember that this relationship between a stretch and force is true to some point, because the curve is something like this. Then when you get to here, the increase in a stretch increases the force, but anything after that, and I'm not getting into detail because we don't have the time for it, but as you get to about that point, the heart muscles are going to be too stretched out, therefore they will not be accomplished what they need to do to push the blood out. So the most important point here is that the concept of preload, the stretching of the heart, allows the force of the heart during the contraction to increase. So as you return more blood to the heart will be stretched more, and therefore as a result it creates a stronger force. So here is another component that we can add to it. How do I return more blood back to the heart to increase the preload? Basically, how can I load the heart more that allows me to stretch it and create a stronger force? The most important thing you can do is to increase venous return. Venous return, again, is the amount of blood that is returning to your heart. So look at these arrows. if your venous return is more, so more blood is coming back to the atria, and more blood is going to go down to the ventricle, so your end diastolic volume is going to increase. If this number goes to about 130, then your stroke volume will increase to about 80, and therefore it would be basically, let's say, 75 times 80 instead of 75 times 70. So I'm not good with math, so this number would be higher than your normal cardiac output, and that is your goal here. And what you see as increase in diastolic volume, increases in the stroke volume, has to do with the fact that your heart's going to be stretched, therefore the force is going to be stronger, therefore your stroke volume will be higher. Now the second concept we want to take a look at is the concept of contractility of the heart. Now I'm not going to go into a lot of details about this since we haven't really looked at the myocardium and how does that work. But one thing you should know is this. If you're looking at the contractility of the heart, if there is there's a structure in your heart muscles called the sarcoplasmic reticulum, which stores calcium, and calcium is essential for muscle contraction. Again, without going into details about this, if there is an increase in calcium, muscles are going to do what? They're going to contract stronger because they make more, the reason for it is they make more connection, I don't know why it does that, more connection, which means basically a stronger heart beat. Now the connections that we're talking about, the reality of it is they're called cross bridge, but we're not going to get into that because again, it's not essential for you guys to know. But if your heart is releasing more calcium, there is more connection between the components of the components within your muscle fibers, and those connection causes the heart to beat stronger. Please do not confuse this with a stretching of the heart as a result of Frank-Starling law. This is nothing to do with the stretching of the heart. It is how strongly your heart is contracting, how hard it is squeezing. So if you have high calcium level, which is usually stimulated by the sympathetic nervous system by release of epinephrine. If you guys remember, sympathetic is basically a fight or flight response when we're dealing with a lot of stress. If you have the sympathetic nervous system activated, there would be a calcium influx, and that leads to the more cross bridge, which means a stronger muscle contraction. And if you have scenarios where you have acidosis, a high level of hydrogen, too much potassium in the outside, or if you're taking medication, which is called calcium channel blockers, all of these lead to the heartbeat to be more feeble and not as strong as it can be. And therefore, there is less blood being pushed out of the heart, and that means your end systolic volume would be slower or less. The third one, which is the afterload, I don't need you guys to know it. It is an important concept, but I will not be questioning you on that for your lecture exam. Now, if you guys remember, as we talked about this earlier in the same PowerPoint, we mentioned that cardiac output is made up of heart rate times a stroke volume. We have talked about the stroke volume. So now let's say that, as I mentioned, a stroke volume is not a source that I can change. I cannot increase the contractility of the heart or the preload or venous return, and therefore this option is out. But I still need to maintain a cardiac output. So the way I do that is by increasing what? Your heart rate. So heart rate increase can be done through three means. Autonomic nervous system, which is again is your sympathetic nervous system, the fight or flight response. And the goal or the targeting for that is your SA node and AV node. SA node and AV nodes are your intrinsic conduction system. So increase in SA node and increase in AV node leads to increase in heart rate, which basically you create more electrical impulses. Each of those electrical impulses leads to a muscle contraction, which means your heart rate increases. The other option is, as I mentioned, is a hormone called the epinephrine. This is also released by a gland called adrenal gland. You don't need to know the name of the gland, but it has similar function to what you will see for the sympathetic nervous system. It will increase heart rate and how strongly your heart actually beats. So it causes the influx of calcium, which causes an increase in contractility of the heart. Last one is the concentration of the ions that are present inside and outside the cell. The most important ones being calcium, as we just discussed, and potassium, another main ions that is essential for repolarization of the heart. So any imbalances in these two main ions, including also sodium, but we don't highlight that right now, increase or decrease in the concentration of these two ions can cause major changes in the heart. And what these changes are, either you have high levels of them or low levels of them depending on the cell. So they're depending on the condition. So let's take a look at these conditions. When we use the word hypo means below, calcemia means calcium. So low calcium basically means you don't have enough calcium to carry out the actions of the heart. That simply means that you're depressing the heart. Your heart, there is a decrease in heart rate and there is a decrease in contractility. If you have hypercalcemia, you have way too much calcium, then you have the opposite effect. You have an increase in heart rate, so heart rate goes up, as well as increase in the force of contraction. Both of these can cause significant damage in long term. Hyperkalemia, which means high potassium levels, has a significant effect on the electrical impulses of the heart, because if you remember, potassium is essential for repolarization of the heart. So if you have way too much of this, that can result to heart block, and if it persists, it leads to cardiac arrest. This is something that is typical on individuals with a kidney disease and are undergoing dialysis. So if they don't do their dialysis properly, there is a built-up of potassium in their system, which could lead to cardiac arrest. Hypokalemia, on the other side, leads to a feeble heart rate because, again, you can depolarize the heart properly to create your next electrical impulse, and it creates a specific type of arrhythmia. So if you have scenarios that basically influence causes an increase in heart rate, we refer to those as tachycardia, which basically means increase in heart rate above about 100 beats per minute. And bradycardia is opposite of this, where your heart rate drops to about 60 beats per minute. And in this scenario, usually heartbeat is not sufficient enough to provide enough circulation for the body. Last part of this PowerPoint, we're going to focus on some of the common medical conditions associated with the heart and its cardiac output. Typically, we categorize these imbalances under congestive heart failure, or CHF. This is a process that basically gets worse over time, so it's a degenerative problem. It can be a result of four main conditions, not the only reason, but four main conditions: coronary arteriosclerosis, persistent high blood pressure, multiple myocardial infarcts, and dilated cardiomyopathy or DCM. So coronary arteriosclerosis, what it is basically a clogged artery. So if any of the arteries that are associated with delivering blood to your heart, through the coronary arteries, basically, blockage in the coronary arteries, part of your heart will not receive enough oxygen, and those cells, I should say, if there is limited circulation because of partial block, what you have is coronary arteriosclerosis. Heart become hypoxic, which basically means hypo means low, oxic means oxygen, so it means it doesn't get enough oxygen, and your heart muscle becomes weak, and circulation becomes insufficient. However, if you have this coronary arteriosclerosis continuing, it could also lead to multiple myocardial infarcts, which basically part of your heart muscle will not receive oxygen, and that means that your heart cells are going to die. Heart cells die because of no O2, and these heart cells will not be able to be replaced with contractile cells. They just get replaced with the scar tissue. In a sense, they are basically losing their ability to be contractile force or create a contractile force, and therefore your heart becomes weak. So the blockage and death of the cardiac cell is known as heart attack or myocardial infarcts. Persistent high blood pressure puts a lot of significant force on your blood vessels, and because this pressure is originating from the heart, your heart is basically overworked, and therefore the muscle starts to weaken over time, and that could also lead to a decrease in your cardiac output. And lastly, dilated cardiomyopathy or DCM, typically associated with weakening of the heart muscles as a result of stretching, for high consumption of drugs, or chronic inflammation of the heart, which both results into significant stretching of the ventricles. Heart muscles become feeble, and therefore they will not be able to pump. All of these are considered to be to result in congestive heart failure, which basically means your heart will be losing the ability to act as an effective pump. So that's about it. That is your last PowerPoint for your exam, and we'll continue with your lymphatic system for the following unit.